Welcome to OncoPharm. I'm your host, John Bazar. I am a professor of pharmacy practice here at the supporting sponsor of this podcast, ETSU's Bill Gatton College of Pharmacy. The World Conference on Lung Cancer wrapped up yesterday in Barcelona, Spain, and so have some updates to talk about centered around EGFR-mutated non-small cell lung cancer, about COMPEL, updates on FLOR2 and MARIPOSA, and the NEOADAURA study. So let's start with COMPEL, which was, sadly, the most compelling that I came across. And I say sadly because I had to make that pun. So this was a relatively small study. It's 98 patients with EGFR-mutated metastatic non-small cell lung cancer. About a third of these patients had CNS disease, and they had been on osimertinib for 20 months when they progress. So I want you to imagine you have metastatic cancer, you've been on this tablet for 20 months, and the disease progresses. There are two ways to look at that. Two extremes. One is the drug failed. We've got treatment failure, we have to change treatment to chemotherapy, for example, right? That's what most people would do. You may also say, or that's what a lot of people would do. You may also say, well, 20 months is pretty good, especially if you see the disease shrunk, you had a good partial response, and then you have maybe a mixed response where, something like a lot of the disease in the chest is still under control, but there's a new site of metastatic disease. Maybe you could irradiate that and continue your osimertinib because the drug has done pretty well for 20 months. And so what this asks, and we know that stopping kinase inhibitors can sometimes lead to a very hyper-progression of that disease. And so what this study is taking, or is asking is it better to continue the osimertinib plus chemotherapy, or just do chemotherapy, in this case placebo plus chemotherapy? And so these patients have progressed on osimertinib. They're either continuing osimertinib beyond progression with chemotherapy, or they're getting chemotherapy with placebo and stopping their osimertinib. So the median progression-free survival here was 8.4 months with osimertinib plus chemo compared to 4.4 months with placebo plus chemotherapy. So that's a hazard ratio of 0.43, 95% confidence interval 0.27 to 0.7. So pretty good improvement in progression-free survival, clear separation of our Kaplan-Meier curves. The median OS was 15.9 versus 9.8. That hazard ratio and 95%, the 95% confidence interval crosses 1.42 to 1.43, point estimate 0.71. Small study, 98 patients. It was actually stopped early because of, quote, changes in the treatment landscape. And what they should say is because people on progression now can do amivantamab and lazertinib. I think this is a really, even though we were underpowered, they still didn't even meet their power they wanted to for the primary endpoint of progression-free survival. So this improvement in PFS is still, that 95% confidence interval is 0.27 all the way to 0.7. So very wide, but I think there's probably going to be some patients who would still continue to benefit from continuing osimertinib plus chemotherapy in these patients. In other disease states, so think of metastatic prostate cancer, even if these patients become hormone refractory, we still continue their LHRH analog. We still continue their Lupron or their Leuprolide, because we know that there's some population of the prostate cancer cells that are suppressed by androgen deprivation. And if you take all that away and then unleash the testosterone, those clones are going to start to grow really quickly. And so one of the theories here is, there's some resistant clone to EGFR, but if you take away all your EGFR inhibition, there's probably some suppressed clone that is would still be susceptible to EGFR inhibition and then can start to take off and run pretty quickly. So that, I think, is compelling. At the time, at least, in the past, that was kind of the option, is if you progressed on EGFR, you're probably not going to change them to an early generation TKI. You could do chemotherapy, or you can consider osimertinib based on how florid the progression is. Is it just, one side of progression or lots of progression? Those are the things to think about. So it's not just that simple of changing to chemo or continuing chemo plus osimertinib, especially with a small study. But interesting study, nicely done study. Happy to see that. The next two studies are both updates of prior studies in the first-line treatment of metastatic EGFR-mutated non-small cell lung cancer. Let's talk about FLORA2. So this was published originally in the New England Journal of Medicine in 2023. This is chemo plus osimertinib compared to osimertinib monotherapy first-line treatment. And back in 2023, the initial publication showed a statistically significant increase in progression-free survival. The chemotherapy was 4 cycles plus carboplatin and pemetrexed, followed by pemetrexed maintenance. Probably ought to do a landmark episode on pemetrexed maintenance here. I haven't done that one yet. Now, at the time of that study, about 50% of the patients on the osimertinib arm got subsequent chemotherapy when they progressed. What we see in the slides in this updated analysis that was presented at the World Conference on Lung Cancer is that 72% on OC monotherapy got chemotherapy on progression. And the big takeaway here is we're seeing a statistically significant improvement in overall survival with OC plus chemo compared to osimertinib, and that's with most of the people on osimertinib getting chemotherapy at progression. So our median OS for both arms for the OC plus chemo was 47.5 compared to 37.6 months, hazard ratio of 0.77, which was statistically significant with our 95% CI of 0.61 to 0.96. This is about 57% data maturity, so we're more than halfway. And our 48-month overall survival was 49.1% in the OC plus chemo compared to 40.8% in osimertinib, and that OC plus chemo has been noted to be the longest median overall survival, or the longest survival reported in a clinical trial of EGFR-mutated non-small cell lung cancer. That's a difference at 4-year OS of 8.3%. That makes a number needed to treat 12, so pretty large impact, pretty large effect size here. So it's, looks like, talks like, smells like a new standard of care, which is OC plus chemotherapy for those patients who would be fit to receive chemotherapy. You maybe would argue that amivantamab and lazertinib would be perhaps a standard of care competitor to osimertinib plus chemo, and that is based on MARIPOSA. We had updated results of MARIPOSA also presented at World Conference of Lung Cancer with simultaneous publication in the New England Journal of Medicine this week. So this is amivantamab and lazertinib compared to osimertinib monotherapy. Median OS not reached in the lazertinib study. This is not quite as long a follow-up, something like maybe 3 years of median follow-up. We have longer follow-up with FLAURA2 than MARIPOSA. We had the improved PFS in the past. We now have overall survival improvement. So the OC monotherapy median OS was 36.7 months. That might sound similar because it was 37.6 months in the monotherapy osimertinib for FLAURA2. So very similar performance here in a cross-trial comparison. Hazard ratio 0.75, 95% confidence interval, 0.61 to 0.9. So very similar, both point estimates and 95% confidence interval. We have a 36-month OS reported here for amivantamab, lazertinib compared to osimertinib. Those rates are 60% and 51%. If you look at FLAURA2, which also reported 36 OS months, 36% OS data, 63.1% with OC plus chemo compared to 50.8, let's call that 51% with osimertinib. So even if you do this cross-trial comparison that we're not supposed to do, we're seeing the exact same performance at 3 years for osimertinib in both arms, and 60 with amivantamab plus lazertinib, 63% with OC plus chemo. Shouldn't say that that means OC plus chemo is better, I would say, with cross-trial comparison, but comparable. I think the big difference between, if you're considering amivantamab lazertinib in the first-line setting compared to OC plus chemo in the first-line setting is tolerability. Amivantamab lazertinib had a lot more toxicity than osimertinib monotherapy. The publication and the writing, they say that there was a 40% rate of venous thromboembolism, which includes DVTP and, quote, other things. If you look at the table, it has a VTE rate of 16%. So they're including some other stuff that I'm not sure what, but 40% VTE rate is pretty striking, and we know that amivantamab plus chemo should get prophylactic anticoagulation, which was suggested but not mandated, it looks like, in MARIPOSA. So that the treatment landscape here for metastatic EGFR-mutated non-small cell lung cancer has evolved a little bit. This week, I think that we have excellent options for patients who aren't candidates for chemotherapy with osimertinib monotherapy. And then OC plus chemo, I would tend to prefer over amivantamab plus lazertinib just from a tolerability standpoint. The rates of paronychia with amivantamab lazertinib is close to 70%. A lot of hypoalbuminemia, a lot of VTE, a lot of swelling. So it looks to be more toxic than OC plus chemo. All right. The last study I have to talk about, I don't know if it was presented at World Conference on Lung Cancer, but who cares, because it was published in JCO this week, and this is NEOADAURA, which you could guess from the name is neoadjuvant osimertinib, because all the osimertinib studies are at aura, or have aura somehow. FLAURA, first-line aura, adjuvant aura, neoadjuvant aura, or aura. This was a decent-sized study, 358 patients, and they're randomized 1:1 to osimertinib alone, osimertinib plus chemo, or placebo plus chemo in the neoadjuvant setting, and they're doing the TKI for at least 9 weeks, and chemo for 3 cycles, and then surgery within 12 weeks of randomization. So they're doing basically 3 months of treatment and then surgery, say, like 3 weeks later is kind of how this works. They're looking at a couple different things here. I should say all these patients are resectable. So they're stage 2 to 3B, but they're deemed resectable. And this leaves a question not tried to be answered by this, which is could we convert people who are not resectable medically or surgically to resectable with this? We do see from this study that many of the patients with N2 disease, which is a hard surgery to do, that there was downstaging in that, but there were only, I think, 50 patients or so in that subgroup. The first endpoint they looked at here was major pathologic response, which was 25% with osimertinib monotherapy, 26% with OC plus chemo, and just 2% with chemotherapy. Now, that's almost all the cancer is gone, but it's not a pathologic complete response, which is the data that was really compelling with neoadjuvant chemo and immune checkpoint inhibitors in non-small cell lung cancer that doesn't have driver mutations. So this is pathologic complete, major pathologic response, not complete. And the complete response rates are not as impressive here. The other endpoint they report is event-free survival at 6 and 12 months. Only 15% data maturity here. So this is really early. This is like trying to predict who's going to win a basketball game at the first time out, okay? But the 12-month event-free survival rate was 83% with chemo. That's kind of the starting point. And then it's 93% with osimertinib plus chemo and 95% with the osimertinib arm. And of course, what we have to consider is after they have surgery, we now have this data about ADAURA and adjuvant osimertinib. And it wasn't mandated that they all get adjuvant osimertinib, but it was provided by the study sponsor, and more than 80% in all 3 groups did get adjuvant osimertinib. So looks like it's a nicely done study from trying to give us some answers. I just think it's too early to know if there is going to be a role for neoadjuvant osimertinib, at least right now. So something that I don't think is actionable, unlike maybe the results of FLAURA 2, but something to continue to watch and monitor and look for down the road. So that is what I have this week. Thank you all so much for listening and all that good stuff. And until I talk to you again, remember, doses matter.